Week 5 of our class, we now start Chapter 15, and this lecture is going to focus on the first part of Chapter 15. So we're going to call this 15A, talking about epilepsy and the therapies for that condition. Now, lately, at least in my own experience, I haven't heard a whole lot about epilepsy, but it is a major medical disorder that affects people in many different ways, and it's surprisingly common. So, roughly about 4% of the population, or 1 in 26, a little bit less than 4% of the population, is diagnosed with some type of epileptic disorder. And that's to the tune of somewhere around 150,000 Americans each year, costing many billions of dollars in terms of either lost productivity or accommodation for that condition. It's a sort of self-reinforcing set of brain waves that leads to these phenomena we call seizures. Brain waves do have a resonance to them. That is to say, our brain waves behave sort of like a tuning fork in some respects. And what can happen though is that these circuits can become self-reinforcing, so that you get this sort of recurring set of brain waves that leads to loss of function for short periods of time. Epilepsy, like many chronic diseases, is multifactorial. People can develop epilepsy in non-genetic ways, or they can have family history of seizures and epileptic disorder. So it's because it's a neuronal circuit situation. So things that can cause changes in the neuronal circuitry can lead to the possibility of seizures. And there are age-related epileptic disorders. Basically because what happens is neural circuits develop that become self-reinforcing. So infections can do this. The link to dementia is not fully understood. Head injuries can do this. Genetic patterning can do this. And any type of pathophysiology in the brain can contribute to the onset of an epileptic presentation. Just a little PSA here for those of you who haven't had any first aid training or haven't experienced anyone going into a seizure. Probably the number one thing that is problematic for seizures is that they are a loss of dignity first and foremost. It's a very embarrassing and a vulnerable time for these people. But there's also a lot of public misconception about what seizures actually represent. And the first thing you should know is that most seizures are not medically dangerous. Um, you don't have to protect them by putting something in their mouth, that sort of a thing, especially your fingers. There have been instances of amputations where people have tried to clear the airway of someone in a seizure and had their finger bit off. So it's not a good idea. What you want to do is you want to time the seizure. If you happen to find yourself in close proximity to somebody with a seizure, one of the things that you should do is note the duration of the seizure, because that's where the truly life-threatening phenomena can occur if someone has a recurring seizure or a seizure longer than a certain period of time. You don't have to constrain them. What you want to do is protect them from injuring themselves. If you go on to social media, particularly Twitter, and do seizure, you'll see lots and lots of entries there. It's a surprising number of entries every day, including people who fall in front of subways, while having a seizure, and people, really gallant rescues. But the truth is, seizures, by and large, are just a momentary unconsciousness, and the biggest threat to the person having a seizure is falling down or falling into a dangerous position, like, for instance, with a subway or off of a chair or something. I actually experienced this as an instructor. I had a student. We were doing a tense unit at a slow pace, about 2 per second, and that recurring stimulation triggered her into a seizure, and she'd never had seizures before. Didn't realize that she had had this condition. But she just about, if I hadn't been standing next to her, she would have fallen off of her lab stool and hit the floor, and that might have been potentially injurious. So what you want to do is you want to get them in a safe place, put them on their side in case they vomit or something. But what you want to do is just let it run its course. That's the number one thing you can try to do, is protect the patient. Let it run its course. They usually will come out of it after just a few seconds. Not every seizure is like this. This is an example of what's known as a grand mal seizure. That's actually a relatively uncommon form of seizure. Many are usually much more mild. But I wanted to show you the EEG tracing. So here's a person with a normal EEG, probably resting with their eyes closed, something along those lines. It's hard to tell. I'm not very good at interpreting these things. I can recognize certain waveforms, and it looks like their eyes are closed in this one. Pre-seizure, what you see is a loss of stability. You're starting to see a sort of a resonance frequency appearing, particularly in these electrodes right here, and you can see that resonance tends to spread, and you start to get these rapid and violent depolarization events during, in this case, a grand mal seizure. Other types of seizures, what you would see is you would see the areas constrained. So you would see something along these lines, but you wouldn't see departures from frequency in the others. Post-ictally, what you see is a recovery state. One of the issues post-ictally is metabolic situations in the neural tissue that may lead to other problems. Again, a multifactorial situation. There are lots of reasons why epilepsy occurs, including that almost 3/4 are idiopathic. That is to say, the seizures just happen and we don't really know why. There are determined causes. You can have family histories, so if a family does have a history, but trauma, surgery, infections, tumors, drug use, patterning issues. This is an example of a congenital situation that leads to neuronal patterning, or drug withdrawal overdose, all cause these things. The most four common causes are infection and trauma, secondary to things like concussions or post-traumatic brain disorder. Tumors, anytime that you have an impingement and or potential change in the perfusion of neuronal tissues, particularly in the cerebral cortex, that can lead to onset of seizures. And that same goes with stroke. What you have going on is a perturbation of cerebrovascular perfusion. All of these things are cause for potential epileptic type manifestation. So to dial down a little bit on what's actually happening when we see a seizure initiated and occur, this will give us some insights into what are some of the things to think about therapeutically. In terms of most seizures, and the vast majority of seizures, you have some sort of an origin or a focus area. In the case of recurring seizures, like in epilepsy, you have what's called an epileptogenic focus. That is to say, there are a bundle of neurons shown here in this functional MRI, and then a little bit over here in this CAT scan. You have a bundle of neurons that are acting almost like pacemakers in the heart. But instead of being good pacemakers, they're actually bad pacemakers. This focus is the usual area that triggers that sort of recurring, self-reinforcing waves of depolarization that we characterize as a seizure. And in epilepsy, these things are chronically hyperexcitable. That is to say, their membranes are unstable enough that they will go into a depolarization of their own accord. And that's why vascular issues and trauma can be a cause of epileptic disease. The consequences, and again, this plays into the therapeutic philosophy, the therapeutic ideas for epilepsy. ATP goes way up in the brains of people who have had seizures by almost 2.5-fold, and that has very, very important metabolic consequence. Certainly an increased demand for oxygen, because neuronal tissue can only use oxygen to create ATP. It can't create ATP anaerobically. And blood flow will also increase by virtue of metabolic need, but also because of that adenosine triphosphate release. Adenosine ATP and its metabolites are potent vasodilators in the cerebral circulation. So all of these things will play a role as well as this focus, will play a role in the therapies that we're going to use to treat epilepsy. In terms of the neurochemistry of epilepsy, particularly classic epileptic disease, what we see is an imbalance between the excitatory neurotransmitters, acetylcholine, aspartic acid, and glutamate, with the inhibitory neurotransmitters, particularly gamma aminobutyric acid, also known as GABA. GABA is well described as a hyperpolarizing neurotransmitter. What do we mean by that? It means that we're making the plasma membrane of these neurons more voltage charged. That is to say, they become more negative, which means that they fire fewer action potentials. More polarized, hyperpolarized means fewer action potentials. And so GABA will cause hyperpolarization. And hang on to that. This is not to be let go of, because when we talk about other disorders, we're going to talk about GABA in particular. So make sure that you remember that GABA is an inhibitory neurotransmitter. So if we have issues with GABA, so if we have too little effect of GABA, that can lead to seizure disorders. Again, an imbalance between the pro-excitatory neurotransmitters and the inhibitory neurotransmitters. So if you have less inhibitory neurotransmitter, like for instance, blocking the receptor for GABA, or you don't have enough GABA secretion, then we would have things like increased hyperactivity in those neurons. So we get a sort of a positive feedback cycle. We get more and more neuronal discharge, a hyperactivity type situation. So these excitatory neurotransmitters get out of balance with the inhibitory neurotransmitters, particularly acetylcholine, aspartic acid or aspartate here, or glutamate. These are either over-secreted or we have some sort of a deficiency in the inhibitory. And we think more often it's the deficiency in the inhibitory. But nevertheless, these now become targets for pharmacotherapy. So when we look at those EEGs, we see that positive feedback occurring, leading to increasingly synchronized and bursts of action potentials. So a loss of the inhibitory system and or an uptick in the excitatory system leads to genesis of seizures. This idea of those flashy stimuli leading to seizures could be possibly a pro-excitatory triggering that sort of rhythmic pulsatile firing that leads to a seizure. Along those lines, as we fire off these neurons, we're going to start seeing issues with ion channels. That includes sodium and potassium. This says Ca negative, that should be chloride negative. These things may cause seizures. So this is actually a mistake in this slide. It should be Cl minus, not Ca minus. So an imbalance in ion channels or an imbalance in neurotransmitters can all lead to issues with possibility of epilepsy. It's a complicated set of disorders, and I'm not asking you to fully understand it, but I do want you to understand GABA, the idea of a negative regulatory neurotransmitter that hyperpolarizes, and excitatory neurotransmitters that depolarize, and or the ions involved with those neurotransmitters that may contribute. So it may be actually outside of the neurotransmitters altogether. So it is fundamentally a balance between the signals that would lead us towards a sort of pro-excitatory seizure situation and anti-seizure situation, the inhibitory side of it. The pro side, again, acetylcholine, aspartate, or glutamate, anything that would trigger increased sodium influx or calcium currents, depolarization events would all be driving the seizure situation, whereas potassium, chloride, the sodium potassium ATPase. The pH can also drive an anti-seizure situation, and that's where we're going to go pharmacologically. Before we go there, though, it's also important to understand that we're not going to treat every type of seizure the same way. We are going, it's a spectrum, and so we do need to tailor therapy and tailor interventions based on the types of seizures that a patient is likely to experience. Seizure disorders, and this can be the most minor seizure to the most significant, do tend to follow a sort of sequence of events that occurs. The seizure sequence, if you will. It begins with instability in resting membrane potentials. That can be a triggered type of a situation where a certain type of, for instance, people who have classic epilepsy, if they see a recurring flashing pattern, can be triggered into a seizure. There was a case not too long ago with a journalist who was known to have epilepsy and was sent an email that had an attachment, and the attachment was a flashing thing, and it sent him into a seizure, and that was considered actually an act of assault on the part of the person who sent the email with bad intention. But you have this resting potential instability. Then you begin to see bursts of action potentials in what we call hypersynchronization. What you see is that you'll see the waves grow in frequency and intensity, and you see the waves starting to synchronize up in these bursts of action potentials. The higher the amplitude on an electrocardiogram or an electroencephalogram means more cells are depolarizing at the same time, or in the same direction in some cases. It's a hypersynchronization type of event. You can have tonic phases if they're having body convulsions where they will contract certain muscle sets, followed by a clonic phase, repetitive jerking type situations with the clonic phase. And then you finally have what's called a post-ictal state, where they're usually fatigued, they may be sore, they may have less lowered level of consciousness. This is sort of a post-metabolic, a post-ictal metabolic state, if you will. Hopefully they don't go into a secondary seizure. They recover fully from that first one. When it comes to seizure disorders, there is a spectrum, just like many neurocognitive and neurofunctional disorders. We see a spectrum, and clinicians and caregivers have tried to categorize them in order to establish reasonable care protocols. You can have the big seizures, the bilateral generalized type seizure, grand mal would fit into that. And you can have almost everything in between. You can have very, very focal seizures, things that occur just within a very, very specific discrete area of the brain, including the conscious center, or in between. You might start with a partial that then spreads and becomes more generalized over time. The biggest single situation, and this is why we want to time seizures and to monitor seizures in terms of for temporal reasons, is this idea of status epilepticus. And there are certain criteria that drive status epilepticus. You can have a single seizure that lasts more than 30 minutes, but that's exceptionally rare. What we typically more commonly see is this, is that if you have any seizure that lasts longer than 5 minutes, that's a risk of status epilepticus, and they need to be seeing a significant caregiver as quickly as possible. Or if they have recurring seizures within a 5-minute period or without returning to normal level of consciousness. It may be that they're no longer convulsing if they're having a convulsive seizure, and they may just still be unconscious. So they're still having a seizure. It's just that they're not having that classic convulsion seizure. But if they haven't regained consciousness and they go into a second one, that is a very, very important criteria for what we call status epilepticus. So let's get into some of the deeper pathophysiology, the pharmacology, if you will. As you can see in this slide, we have any number of ways to classify it. I've already sort of talked about the classification. The book wants to talk a little bit about classification, where it focuses on things like simple partial seizures. That is to say, relatively localized, the sort of mildest form of seizures. You can also have complex partial seizures and so forth. Just follow the book in this section. It really isn't, we don't need to get into all of these, and you will probably get into more of these, particularly in other classes, I would suspect. We often think of seizures as being something that involve neuromuscular convulsions or that sort of thing, but that's actually quite far from the truth. And like I said earlier, these things do involve a spectrum and can be very, very localized and very, very specific. For instance, we are going to look at therapies for what are called petit mal, or otherwise known as absence seizures. This is the sort of, they space out, but it's more than just that. Usually people, when they're sort of spacing out, are still somewhat attentive. In this case, these people pretty much lose all of their focal consciousness for a period of time. This sort of vacant stare or an eye roll or fluttering eyes or some sort of lack of response, even though they may have their eyes open. My student in particular never closed her eyes. She sort of puffed her cheeks and then just literally started rolling off of the bar stool. If I hadn't caught her, she'd have hit the floor. But it's something where we see this sudden lapse in consciousness, staring blankly into space, usually lasting less than 15 seconds, and that's still considered a seizure. If we were to look at the brain activity, you would actually see a hypersynchronization occurring. And there are drugs that we're going to take that are different from the sort of generalized seizures that we are more likely to think about when it comes to this disorder. Another example that we will look at for just a little bit, and I'm going to talk about here in the next slide, are known as the tonic-clonic seizures. It's one of the several generalized seizures that involves significant neuromuscular stimulation. So we're going to talk about that for just a second. Again, the idea of you understanding the disorder so that you can understand why we would give certain types of drugs. Folks who do suffer from recurring tonic-clonic seizures are often significantly impacted in society and may have therapy animals to help them recognize when they're about to go into a seizure. As I mentioned in an earlier slide, someone going into a seizure is in an acutely vulnerable state. If you go onto someplace like Twitter and read about people's experiences with seizures, you hear about people losing their wallets while somebody goes into a seizure, and you also hear these heartwarming stories. So people who undergo particularly these generalized seizures either get good at recognizing their own progression into a seizure, or they'll have an animal that is good at recognizing the biochemical signature going into a seizure before they actually do. They go into a tonic phase where you see jerky movements. Usually they've lost consciousness at this point. You see a tensing. That's what tonic means. You see a generalized, intense muscular contraction event, often with jerkiness or tremors. The clonic phase, on the other hand, and you can sort of go back and forth between these, is a more shuddering, convulsion type twitching situation. Occasionally they will stop breathing. This is not this usually only lasts for a few seconds. I've seen this a couple of times myself. What typically happens is their breathing pattern will stop, and then eventually their CO2 drive will kick in and they'll start breathing again. But you want to watch them just in case. If you have to give them mouth to mouth, as long as they're not actively convulsing, it is possible. But again, usually it self-resolves. And then post-ictal, they're usually lower level of consciousness. They're either sore or exhausted from this neuromuscular and neurocognitive seismic event. There's actually a relatively simple way to break down the issues of complications when it comes to epilepsy. And one is the loss of motor control in dangerous situations. And secondly is mental health. Now, there are some other complications, so let's go through some of the most common. The first one, car accidents. People with severe or unmanaged epilepsy do not qualify for, many states won't allow them to drive because of the fact that they could have a seizure while they're behind the wheel. The instances I can think of are when they're subjected to repetitive stimuli, like for instance, a bump 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 bump, where the road is creating a resonant frequency that might induce a seizure. Drowning. So people are much more likely to drown. Why? Because they would lose motor control, lose consciousness. Somebody might not realize that they're missing. So people that have epilepsy, if they do desire to swim, should be swimming in extremely controlled situations where there's a high degree of observation, depending on how severe their situation is. But like I said, emotional health difficulties. This is due to the fact that we live in a very dignity. Um, we tend to live in an independent oriented society where people are striving during the course of especially their young lives, to achieve independence and self-sufficiency. So if you lack that, and profoundly lack that to the point where you might be taken advantage of in terms of theft or sexual assault or those types of things, anxiety about having a seizure, depression, and this isn't necessarily restricted to simply to epilepsy and seizures. There are instances of other types of shall we say, non-life-threatening, but recurring loss of dignity or so forth. Like for instance, you'll see depression in folks that have persistent hiccuping. Chronic hiccups suffer from depression quite often. Suicidal thoughts and actions due to this emotional health impact, this vulnerability in a society that values self-sufficiency. Certainly falling. Anytime that you're in a position where you can fall, even from a flat surface, can be potentially problematic. Never mind when you're in a risk of a higher fall or a more severe fall. Yes, there are pregnancy-related complications. This is due mainly to the side effects of the medications. So someone with epilepsy who desires to have a baby needs very, very careful consultation, and we will talk about that coming up. The less common but more serious, status epilepticus, where you have repetitive or extended seizures. Again, that's less common, but a fairly serious possibility. And I won't belabor the point with this slide, but it does show you some of the issues when it comes to emotional behaviors, mental situations, cognitive issues, social withdrawal, denial, that sort of a thing. It's just reinforcing what I've already talked about. So how do we treat epilepsy? Well, we've already mentioned some of the causalities, that either increased excitatory stimuli, like that would lead to movement of sodium or calcium into the cells. That would cause a depolarization. These are cations, they're positive. So more positives inside the cell cause the voltage to rise, and that's an excitatory situation. So we have drugs that are going to counter the sodium influx, so they're going to be anti-excitatory. Ethosuximide, phenytoin, we'll talk about those later on. So we're going to inhibit the excitatory ion channels. Or we are going to stimulate the GABA side. We're going to upregulate the inhibitory side of the equation. And we have barbiturates, benzodiazepines. We'll talk about a few of these as well. So we're either going to downregulate the excitatory side, or we're going to upregulate the inhibitory side. We may also block glutamate. There are examples of that. So we're going to kind of touch on each of these and so one of the reasons and some of the side effects and so forth. So here's a picture to reinforce the idea that what we're going to do is we're going to inactivate the sodium channels. When we activate sodium channels, that causes an influx of sodium from the extracellular region, causing depolarization, which is excitatory. So there are several drugs that, and some that we're going to talk about, that work to block a sodium channel function. So sodium channel inactivation. Or we can block calcium. Ethosuximide is an example, of valproate, sodium are examples that prevent calcium from moving in. There are calcium channels that are depolarizing channels, and so we will, particularly right before the synapse, you have a lot of calcium channels there, and that leads to neurotransmitter release. So we can block those using ethosuximide or valproate sodium to do that. Or we can enhance the inhibitory neurotransmitter GABA. Traditionally, that has been going after the GABA receptor channel. It's a chloride channel, so when it's activated, it lets chloride from the outside in, and chloride is negative, so it causes more negativity inside the cell. So barbiturates, benzodiazepines are all classic examples of these things with a high level of dependency issues. More recently, they've gone after increased GABA secretion, so there are examples of those up here, where what we're trying to do is increase the amount of GABA in the synapse, rather than going after the channel. This figure right here might look a little bit complicated, but what it's trying to do is show you the various targets here in blue that I'll circle here in red for you. Like, for instance, targeting sodium channels and the drugs that do that. Calcium channels that we talked about and the drugs that do that. Something that upregulates the GABA signaling, these drugs do that. Something that tackles the glutamate signaling, these drugs do that, and so forth and so forth. It's just basically a reference slide for you to help you get started with the basic concept of what our poster child drugs that we're going to talk about do. The first drug we're going to discuss is the oldest. It's called diphenylhydrantoin, or just abbreviated phenytoin, more commonly known as Dilantin. That's a much more common name. That's the trade name. It's the oldest anti-seizure drug and still used quite often with patients. It goes after the sodium channels. It blocks the recycling of the sodium channels once they've been activated. So they'll open and they'll close, and this will slow that recovery back to a basal state for the next action potential. And so it slows down the firing of action potentials. Yes, at higher doses, it will also go after calcium channels as well and block that. So it's an anti-excitatory type drug. And when you do that, you get less neurotransmitter secreted, particularly acetylcholine, norepinephrine in this situation, inside the central nervous system. The side effects are primarily drowsiness and lethargy, but there's also a significant cosmetic side effect, and that is known as gingival hyperplasia. So these folks have to be exceptionally good about keeping very, very good oral hygiene because of the gingival hyperplasia issue with Dilantin/phenytoin. You can get issues with getting a type of lupus. You can get occasional inappropriate hair growth. That's particularly an issue with women, and you can have some other lymphadenopathies that are not super important for our purposes. Mostly, it's this. It's these sort of cosmetic things, drowsiness, and lethargy. Our next drug is very, very common, probably even more common than phenytoin at this point. It's called carbamazepine. This category of drug is often termed a membrane stabilizer, and let me explain what that means. First of all, it's going to go after sodium channels. It will slow sodium kinetics, and so it's going to slow down the repetitive firing of excitatory neurons. It does also seem to inhibit norepinephrine kinetics. And norepinephrine is also an excitatory neurotransmitter, but it will thirdly affect GABA. It seems to activate GABA signaling. And so we call it a membrane stabilizer because it's affecting the ion flow across the membrane and seems to sort of slow the kinetics altogether. Let me explain in the next slide. So carbamazepine makes it for a good example by the fact that it seems to do a little bit of several things, which is why it not only can work for seizures, but can also be a pain reliever for what we call neuropathic pain. And let me explain why. It's going to slow down the kinetics of sodium across membrane. That's that membrane stabilization phrase that I used. But it's also doing other things, and that's why I keep carbamazepine, because it's doing a little bit of several different things, and that's more true than not when it comes to neuroactive drugs. It's going to slow down the sodium kinetics, but it's also upregulating GABA signaling. And so it's doing more than one thing. The thing about carbamazepine is that it can trigger some side effects of drowsiness, nausea, vomitings, these sort of, it seems to be affecting the autonomic nervous system. And notice that you want to avoid grapefruit juice while you're taking this type of medication. That's because it alters the kinetics significantly. Grapefruit juice causes activation of certain redox enzymes that then will lessen the effect of the medication while the patient is taking it. And they usually take these things for a long time. Another category of drugs that are usually reserved for more severe forms of seizure disorders are the sedative hypnotics. Barbiturates are the leading class in this. Issues of abuse, though, and we'll talk about that a little bit later. They induce a slower level brain wave, so they tend to cause lowered consciousness, certainly decrease anxiety. That may be part of the appeal to folks who become eventually dependent on these drugs. These guys are GABA receptor agonists, and the barbiturates specifically target the A subcategory of GABA receptors. GABA receptors, if there's one thing you should know about them, is that they are chloride channels. They are neurotransmitter-gated chloride channels. When an agonist activates these receptors, it causes chloride to move into the cells, diffusing into the cells, and thus causing the charge on the membrane to get lower and lower, beyond -70. And so that causes a hyperpolarization, so you have fewer action potentials. Another way to upregulate GABA, besides directly activating the GABA receptors, is to inhibit the enzyme that breaks down GABA. Just like acetylcholinesterase will break down acetylcholine, GABA transaminase is the enzyme that will metabolize GABA into an inactive form. So by blocking the inactivating enzyme, you now have a longer half-life of GABA in the synapse. More GABA means more hyperpolarization, which means less action potentials firing. Our next drug is the frontline drug for those absence, those Petit-Mal type seizures, the ones that we talked about earlier in this lecture. This is ethosuximide, also known as Zerontin. It's a calcium channel inhibitor. It slows calcium channels. And so you have, again, less excitatory phenomena. And these calcium channels are more involved in certain areas of the brain that are involved in sort of awareness moment to moment. It's relatively long lasting, though you can see a difference here. The reason I left those in there is not for your memorization so much as to show you that there can be significant differences in kinetics between adults and children. But it is the first line drug. It's the one that's the drug of choice when you're talking about these sort of Petit-Mal absence seizures. The problem, though, is that it may exacerbate other types of seizure disorders. So a person who is on ethosuximide, they should have gone through the screening for other risk of seizures, and it would not be indicated if they experience not only petit-mal but also tonic-clonic or other types of partial seizures that involve neuromuscular function. And I just included this right here. This is something that you often see in the student community, that's particularly in nursing. They will often come up with these fun little jokes and anagrams for how it affects different types of things. Again, this is probably a little bit beyond our need. We're really talking about calcium channels, petit-mal seizures. I'm not really worried about the thalamus all that much. Our final drug in this session is called gabapentin, and it's going after one more target, and that is it's blocking glutamate. So we had the sodium and the calcium, the excitatories. We also had the GABA drugs, and now we have the glutamate, which is also excitatory. And so what we have going on is we don't really know what gabapentin is doing, but it is slowing glutamate signaling across neurons. So it's kind of cool is that we know it sort of works, but we don't really know how it works. What we see, the side effects: fatigue, drowsiness, dizziness, loss of motor control. The issue with gabapentin is that they don't want to just suddenly withdraw. It can induce behavioral loss of sleep, anxiety type issues. They also, because of its calcium function that we know about it, that there does block some calcium, it helps with tremor and may help with neuropathic pain, kind of like carbamazepine does. So we've been through the drugs, we've been through the pathology. What you will see with patients, if you are involved with working with occupation with patients who have seizure disorders, is that most people can control these things, and we've gotten better. As we understand the neurochemistry and the neurobiochemistry, we have been able to narrow down and control. So roughly 2/3 to 3/4 of the patients are under well control, so long as they observe their appropriate regimen, diet, and exercise, and so forth. But there are about 1/3 of patients that do not control well. And so what they try to do is they try to tag team this. They try to go after more than one target, because that's all we really have right now are those, 4 or 5 receptor or signaling targets. Again, about half of that 30% we can control. The other half just seem to fall short, and so they're trying other things, maybe surgery in some cases. They may try some experimental devices, but there's still work to be done in this area, and so you may find yourself working with patients that are refractory to all of these treatments. But if they're on one and it's not well controlled, you can maybe point that out to a patient to consider alternatives and so forth. So let's use our epilepsy management outline slide here for you to see how we can best integrate this into your standard practice regimen when it comes to managing these, both with drugs and without. The number one thing you can do, in addition to helping them with safety and other aspects of occupation that you guys will be specialized in, is to encourage compliance. Encourage compliance. And this is going to be something that you're going to have with all types of drugs, but especially with epilepsy management, for obvious safety purposes, but also some of the side effects that we discussed. Encourage making it easy for them to comply with their proper schedule. Last couple of slides, I want to talk about some specific female-centered issues when it comes to anti-epileptic drugs. On the surface, one of the things, if you remember early on, Epilepsy is often associated with depression and anxiety. Well, these drugs, while they may lower the incidence of seizures, nevertheless, that may be at a cost in terms of change in facial appearance, hirsutism, gingival hyperplasia, and so we may be robbing Peter to pay Paul, if you know what I mean. That is to say, we're trading certain side effects for others. Weight gain, why? Because we're talking about neurodepressants, and we may also unintentionally be dialing down the neural control of metabolism. There are the obvious cognitive effects, which may lead to, again, psychosocial, social dynamic issues, or loss of what we would call situational awareness. Sedation and loss of cognition mean that you're not able to pick up on either social cues from others, or you may not be aware that you're in a risky situation and thus vulnerable to being taken advantage of. The drug-drug interactions are significant with AEDs, and we have to be mindful of that. We already talked about grapefruit with certain types of drugs. That's because these AEDs do seem to affect hepatic drug enzymes, and so you get a synergistic effect of these enzymes. We've already seen a large half-life difference between kids and adults. And that just illustrates the potential for large swings in kinetics. And so we want to avoid that. We want to know what we're dealing with these drugs, and so we want to minimize that possibility. There is a significant contraceptive and AED interaction. That is to say, they will be antagonistic. AEDs may actually lower the efficacy of hormonal contraceptives. So if someone desires to be sexually active and is on an AED, they are at a higher risk of unintended pregnancy. Vice versa, the hormone may, probably because of drug metabolizing issues, it's hard to say, lowering the efficacy of the AEDs. And if they're refractory and they're taking more than one, the complications that occur because of multi-drug therapy. We have more to say, though. There's more going on here that I'd like to talk about, so we have a couple more slides. The big one when it comes to AEDs is that if someone does become pregnant, whether intentionally or otherwise, the risk of what's called teratogenic, these are birth defects, is up at least 2 to 3-fold. In a normal population, we will see out of 100 pregnancies, 2 or 3 with what are known as birth defects. We call that teratogenicity. Either they have altered shape of limbs, missing digits and so forth, and more severe complications, including things like anencephaly, for instance. In women on AEDs, that number goes up substantially, 2 to 3-fold. And so in many cases, what will happen is that if someone agrees to go on AEDs, they may have to go under a very, very strict regimen of avoidance of pregnancy for the reasons of this risk. And to wrap things up, again, I like to bring this back to, it has gotten to some mechanism today and so forth, but knowing what you know about these drugs now, having a sense of how to manage epilepsy in alongside that drug management plan, tracking seizures, managing the medicines, the pill boxes, the scheduling, working on reducing stress, having a response plan, but also I would include a reproductive plan as well. If you intend to have kids, how will you manage your epilepsy during those times? If you tend to be sexually active, how will you manage your contraceptive needs if you do not desire to have kids during that period? It's very, very holistic approach above and beyond just the pharmacology. And so it's a challenging, but it's also a very rewarding area. And you can really make a big difference in people's lives, understanding the reasons why we want to manage our medicines correctly in these patients. Thank you for your time. We're at 49 minutes. That's long enough for now. And I will talk to you in the next segment. Thank you.